I'm going to get started. Okay, welcome everyone. Thank you for joining today's webinar titled Conservative Management of Gynecologic Cancers and Fertility. I'm Leslie Appiah, Chief of the Division of Academic Specialists in Obstetrics and Gynecology at the University of Colorado and Chair of the Female Scientific Committee of the Oncofertility Consortium. Dr. Terri Woodard is an Associate Professor in the Department of Gynecologic Oncology and Reproductive Medicine at MD Anderson Cancer Center, and she is a Director of Fertility Preservation at Texas Children's Hospital at MD Anderson. She is also a member of the Scientific Committee. She will introduce our speakers today and serve as a moderator. Please type your questions into the chat, or you may unmute yourself at the end of the presentation when we reach Q&A. Dr. Woodard.
Great. Welcome, everyone. We have two fabulous speakers for you today to talk about the conservative management of gynecologic cancers and infertility. Our first speaker will be Jose Alejandro Rauh-Hain. He's a gynecologic oncologist that's on staff here at MD Anderson Cancer Center in Texas. He was born and raised in Mexico City and received his degree from Universidad Panamericana School of Medicine. After finishing medical school, he had the opportunity to work as a research fellow at Mass Gen, and after that, he was actually accepted to their OBGYN residency. After residency, he also did his Gyn-Onc fellowship there and also completed a master's in public health at the Harvard School of Public Health and a postdoctoral fellowship in the program in Cancer Outcomes Research Training Program. Currently, he is a member of the faculty here. His interests are surgical treatment of gynecologic malignancies, and he also does a lot of research in descriptive and interventive studies conducted in real-world clinical settings that may possibly reveal the effectiveness of strategies to reduce well-documented disparities in gynecologic cancer and improve the care of young women with cancer. Following Dr. Rauh-Hain, we will hear from Dr. Kenny Rodriguez-Wallberg, who for many of you needs no introduction. She completed her medical education and her residency in obstetrics and gynecology in her home country of Colombia. She then completed both a pediatric gynecology fellowship as well as her REI fellowship in Paris. In 2005, she earned her PhD degree at Uppsala University in Sweden, and since 2007, she's been a senior consultant in reproductive medicine at Karolinska Hospital in Stockholm, where she heads the fertility preservation program. She is currently an adjunct professor at the Department of Oncology and Pathology at Karolinska Institute and is sharing her clinical work with both clinical and translational research. So without any ado, let's go ahead and hear from our fabulous speakers today.
Okay, thank you so much, Terri, for the very kind introduction. So I'm gonna share my screen. Oh. You know what? I'm gonna have to switch computers. Kenny, do you want? I'm so sorry. Do you want to start? I'm gonna have to switch my computer. I'm gonna have to use my laptop. Okay.
Yes, I can start. It's fine. Let's see if I can share my presentation. Do you see my screen?
Yes, we do. Thank you.
Yes.
Great. Okay. Thank you very much for this invitation and for the kind presentation. As you heard, I work in Sweden, and I am very much interested in fertility preservation for young patients and also girls as part of my clinical work. But when we come up to consult patients, we need to know more about what are the outcomes in terms of efficacy or safety, because the patients also need to make decisions regarding procedures, surgeries, and so on. And for that, it's very important that we are prepared to discuss with our patients what are the opportunities and difficulties that they are going to encounter in the care of their diseases. Cancer is a dangerous disease, and in some cases, for example, when it's treated with surgery, so we have learned to be more conservative. Then there are also other methods for fertility preservation, but just fertility-sparing surgery is a well-known and one of the first methods for fertility preservation that were developed. So conservative management is something that we have learned, but we need to evaluate constantly to be sure that we are not introducing any risks to our patients. As I work in Sweden, Sweden is part of the Nordic countries, so we have special models of care where much of our healthcare is tax funded, which means that most of our patients have the possibility to receive similar care according to certain rules. For example, fertility preservation is offered in the Nordic countries to all patients, but to the females up to an age of 39 years, and after 40, the patients will need to pay for this treatment. But it's because fertility treatments are also considered to be given with the tax-free funding to the whole population. Since many years ago, more than 25 years ago, we started with programs of fertility preservation at many university hospitals. And for you, maybe this is very strange to hear, but Sweden is a large country, but we are only 10 million inhabitants, and we have only 7 university hospitals, which makes collaborations very easy for research and also to have very homogeneous clinical healthcare programs. We started with fertility preservation many years ago, and in this paper, for example, I'm showing you here, we presented 20 years of multi-center experience with 14 centers from the Nordic countries, we having all similar programs for fertility preservation. So if you are interested to learn more, so you can check this paper, but it just shows you that fertility has been in the focus since many years ago, specifically at the university hospitals that have reproductive medicine units installed in their hospitals. And then working this way, so we have been able to collect the cases and to follow the patients, which is very valuable because we can get up to the numbers starting with a very small population as we have, but then we can actually count and we can see if the methods are effective and who are the patients that we are treating. In this paper that I'm showing here, we had 1,254 women and girls, but you understand that fertility preservation is not easy. And the problem is that we don't have a final box where the patients are together, and then after we have to individualize the treatment if the patient is adult, if the patient has a partner, if the patient is a girl. So we have different options to offer. And regarding this number of patients that I have mentioned previously, so we look how many of them had been performing fertility preservation for gynecological cancers, and we had about 120. A little bit above that. In that group, we had 37 with ovarian cancer and two girls with ovarian cancer. And as we have divided the topics tonight, tonight is because for me this is 10 p.m. here in Stockholm, but maybe for you it's another time. For the topics for this webinar, so we have decided that I will focus on ovarian cancer and fertility preservation. So I will start by telling you that when we do fertility preservation, it's very important that we look at the efficacy of the methods we are offering. So in this cohort that I am showing here, that is all the patients combined with all the indications, benign and also malignant. So we can measure the efficacy because if we follow the patients, we have medical records that are electronic, we have registries where the patients are, so we can follow every single individual. And then we can know how many of them actually have had children afterwards. Now, if we focus on just ovarian cancer is very well known as one of the most difficult tumors to diagnose. Is difficult. It usually comes at a late stage when we discover it. But if it is discovered at an early stage, and if the woman is young and is interested in maintain fertility, so we offer these patients the possibility to have a conservative surgery. And when we are doing this, we want to see what are the effects of what we are doing and if it is safe for the patients. Fertility sparing surgery has been proposed and is defined as the preservation of the uterus and at least a part of one ovary, and also offered to women that are of young age and that wish to preserve the fertility function. Because if the woman has already had 2 children or 3, maybe she's not interested in undergoing a conservative surgery for treatment of early stage ovarian cancer. So the first thing we did when we wanted to study this disease was to recruit a doctoral student, and Dr. Gry Johansen, who is a specialist in obstetrics and gynecology, conducted first a prospective study. We call the study PREFER because fertility preservation is an option and is depending on the wish of the patient. And she, in her thesis, was collecting quotes from women that had received a diagnosis of an ovarian tumor at a young age. And she could illustrate with these quotes how important was for the women the loss of fertility as the most potential frightening situation they could consider being. And also, because I am in Sweden, I will tell you a little bit about the possibilities to do research using the Swedish healthcare registration. We have registers for almost everything in Sweden. We have registered for birth. So when you were born, you receive a personal identity number, and this personal identity number follows you during your whole life until you die. And if you get a surgery, so your number is used to register in quality registers for surgery, because otherwise we cannot follow the complications or other effects of interventions. If you pay taxes, so we know where you live, and we know if you are getting married, we know if you get a child. If you deliver a child, you appear in the medical birth registry, and then we can know at how many weeks of pregnancy and so on. We can check all the diagnosis of the pregnancy and also the postpartum, the perinatal health, and we can link your child to the child to the mother, and then we can follow the development of the child in the same way. And using the registries, so this is very used now for research in our country, but also in the remaining Nordic countries that have similar personal identification numbers that are unique, and also similar healthcare systems. So using these registries, we decided to get the information about the women that have done fertility sparing surgery for the treatment of an ovarian cancer in early stage. And the doctoral student, Gry Johansen, she's now a PhD. She did these studies under my supervision. So the registries allow us to investigate all women that have been operated in a conservative way for an ovarian cancer, but also all the women that have been operated in a radical way for a similar disease. And using the information in quality registers for gynecological cancer, we can know all the stage and the size of the tumor and many other details, the type of surgery, etc. And then also using the registry, we can follow if the women had relapse. And using other registries, there is one register that is called the cause of death registry, so we can actually know who of these patients that we are following actually die and when they do it, when they die. So we went to the registry to find all the information on women between 18 to 40 years of age with a diagnosis stage 1 ovarian cancer. Well, ovarian tumor, we also look for borderline tumors in our study, and the type of surgery, if it was conservative or if it was radical. And because you understand that fertility sparing surgery is an election of the patient, there is not the possibility to do a randomized control study for this in this situation. And then when we follow the patients using the registry, we could include patients since treated since 2007. We can follow the patients after years, and then we can calculate the overall survival by comparing the women that underwent the conservative surgery versus the women that underwent the radical surgery. We can also see progression-free survival if we have the data on relapse, and then we use the methods that of Kaplan-Meier for survival analysis. And at the very beginning, I explained to you that Sweden is a small country, so we are not very many. So you can imagine if we started to collect data from 2008 to 2015, all women that were diagnosed with cancer stage 1 that underwent either fertility sparing surgery or radical surgery, they were not more than 493. And in this group, we had epithelial ovarian cancers, non-epithelial ovarian cancers, and borderline tumors. And borderline tumors is actually the largest group in our cohort. So in total, 83 women had epithelial ovarian cancer and 73 had non-epithelial ovarian cancer. You are mainly interested in cancer tonight, but some majority of the women, they had borderline ovarian tumors. And then 71%, as expected, these are women that are young, underwent fertility sparing surgery. And then we wanted to see relapse data, mortality data, and also we wanted to see if the women had children after this fertility sparing surgery. So we could find the data in the medical birth registry that I have mentioned to you. But there are women that do not get a child, but they do fertility treatments, or they do adopt finally, but they can also do fertility treatments. They can do fertility treatments with own oocytes, or they can do fertility treatments with donor eggs. So we also could get the data of the women that have undergone fertility treatment. This is just the survival curves, the Kaplan-Meier curves for all the disease together, just to make it easy, because the picture is not very good. I can tell you that there was no difference in survival, and there was no difference in relapse either between the women that chose to do fertility sparing surgery from the women that actually did radical surgery. The overall survival of this cohort was excellent, 97%. For all the diseases. And we can tell our patients that after looking for patients in similar situations to the patients that we have today, so we haven't seen that fertility sparing surgery is associated with an increase in relapse or death, which is reassuring. Then we also look upon the efficacy of fertility sparing surgery, and we have summarized our data into papers where we present both the safety data but also the fertility outcomes. And what we found out was that most of these women that underwent fertility sparing surgery, they didn't need fertility treatments. The natural fertility was preserved, and they didn't have any higher risks of relapse than the women that were treated with radical surgery. Fertility preservation has been discussed in many groups. I belong to the ESHRE group, and we wrote together the female fertility preservation guideline in 2020. I think this document is still very updated. So if you are interested, you can read a bit on it. And that was my last picture. Thank you very much. These are my clinical team in the middle and my research team to the right. Very well motivated people trying to get information about women, fertility, and cancer. Thank you.
Thank you for that wonderful presentation, and thank you for staying up so late. We know it's late and at 10 o'clock at night for you. We'll now move on to Dr. Rauh-Hain.
Okay, hopefully I can make it work. Okay, awesome. Can you guys see my slides? Yes. Okay. So I'm Alejandro Rauh-Hain. I'm a GYN oncologist at MD Anderson, and I'm going to talk about cervical and endometrial cancer. So this is a very quick overview. So if there's any questions, I'm happy to address them at the end. I don't have much time to really go in depth into some of the studies. So again, if there's any questions or any particular studies that you might be interested in, I'm more than happy to discuss at the end. So I think one of the big things that has led to really the explosion of data about fertility sparing is that we know that women are delaying childbirth. And I think this is a very interesting graph of just looking at different countries and how does the average age of women have changed over the years. And I think it's very evident for the graph that, throughout all of these countries, women are getting pregnant at an older age. And there are different reasons for that. But that is one of the things that now, for us that take care of patients with cancer, that we are seeing more patients that have history of cancer that now want to get pregnant. That probably in the past that was not such a big issue. So if you look at the data from 1990, and this is data from the United States, from 1990 to 2000, women between 35 and 39, there was a 31 increased risk or increased rates of pregnancy, and also that was looking at women between 40 and 45. There was a 51 increase. But not only that, if you look at the data from 2000 to 2014, there was yet another 24% increased risk or increased rate in women 35 to 39. These are kind of the topics that we're going to discuss, and I'm going to focus again in endometrial cancer and cervical cancer. So for endometrial cancer, this is data from the United States. There are around 60,000 cases of endometrial cancer every year in the United States. And the rates of endometrial cancer in the US at least keep increasing. I remember giving presentations 10 years ago, and we used to say it was only 50,000. So endometrial cancer is one of those cancers in which we are seeing a pretty dramatic increase in the numbers. But not only that, we're seeing actually a fair number of young women with endometrial cancer nowadays that in the past we didn't used to see. And part of that is the obesity epidemic that haunts in the United States. So when you look at recent data from endometrial cancer, for premenopausal women less than 50 years old, around 15 of all the endometrial cancers, around 15% are in women less than 50 years old. And that, again, this is fairly new data, and something that I think it's a dramatic change to what we were used to in the past. So in terms of treatments for fertility preservation, we know that progesterone treatments are fairly effective. And I'm going to first talk about oral progesterones, because those were the management that we used to use in the past the first that were pretty much used for fertility preservation. And there are two main oral progesterones, like those are medroxyprogesterone or Megace. The doses for these two agents in terms of that we use for fertility preservation, really there's a huge variation in practice among providers. So there are providers that might use a lower dose, and there's higher dose. And when you look at the literature, again, there's a huge variation in the doses for these two agents. Furthermore, there's been studies trying to look at which of these agents is more effective for hyperplasia for grade 1 endometrial cancer. And there are some studies that suggest that probably Megace is a little bit better than medroxyprogesterone. However, that data is really not that conclusive. But I would say that I think in our practice, if we we're going to use an oral medication, I think most of us would use probably Megace. This is a study that was published by Pedro Ramirez, one of my former partners, in 2004. This is one of the very early, comprehensive studies of using progesterone for grade 1 endometrial cancer. So for this study, what they did is they did a pretty much a literature review of what had been published up to that point for patients with grade 1 endometrial cancer. And this study, just to give you an idea of how much progress we've made since then, included, and again, it was a very comprehensive literature review, included 76 patients. What is important about this study is that what they show is that with the use of oral progesterones, 55% of the patients had a long-term response, 25% progressed on therapy, and 20% of the patients had initial response, but they ended up having a recurrence at some point. Notably, there were no evidence of any extrauterine disease in those that had progressed or had a recurrence. And again, I think the important numbers to remember here is the 55% response rate for oral progesterones, and that 25% of those progress on therapy. And these numbers are fairly consistent amongst other studies that we're going to discuss. This is a study that was published in JCO. The importance of this study is that's a prospective phase 2 study looking at using medroxyprogesterone for patients with grade 1 endometrial cancer and atypical hyperplasia. And it's a very, very, very small study, but again, it's a phase 2 prospective study. And what is remarkable about this prospective study is that the response for the oral therapy was exactly the same as what Dr. Ramirez published in their earlier study. So I think that when we talked about patients with oral medications, usually we say that the response is between 50 and 60%. There have been subsequent meta-analyses that have been published, and again, all of the data seems to be very consistent in terms of the oral progesterone treatments for hyperplasia with Appiah and grade 1 endometrial cancer. So what about obstetrical outcomes? This is again data that was published in that original review from 2004. 20 patients of the 76 patients achieved a pregnancy. So the pregnancy rate was around 25%. What is important also is that 12 of the patients that achieve a pregnancy, so 60%, require some kind of ART in order to get pregnant. And 3 of the patients had a recurrence after pregnancy. But I think what is important is that the pregnancy rate seems to be around 20% about these patients with endometrial cancer, and that the large majority of them would require some kind of fertility treatment in order to achieve a pregnancy. The issues with oral therapy, as you probably know, patients can have significant weight gain. There are some issues with compliance, and there is a significant risk of developing DVTs and pulmonary embolisms. So the other option is to use an IUD with progesterone. In the United States, probably the most commonly used is a Mirena IUD. This is a study, I think a very well done study. It's a single institution study from California, in which they took out around 220 patients that have complex hyperplasia with Appiah. And they wanted to compare is whether an IUD with progesterone was better than systemic therapy. And what they found is that among those patients that received an IUD, the response rate was around 75% compared to 55% to those that had oral therapy. And what is more important about this study is that this effect of IUD apparently being significantly better was more pronounced among those patients that were obese. There's never going to be, I think, a randomized trial comparing a progesterone IUD versus oral progesterone, but this study and other studies might suggest that an IUD might be a better option. And I would say that I think in our practice, at least here at MD Anderson, I think most of us we first start with an IUD, and then if that doesn't work, then we might try oral progesterones, and we can sometimes we actually in some cases we might combine them in unusual situations. This is a study that was published from our institution. Shannon Westing published this study a couple of years ago, looking at what was their experience using a Mirena IUD. And what we saw was a response rate of 75%. We know that the response is much better for patients that have complex hyperplasia with atypia compared to those that have all endometrial cancer. But again, you see these very consistent response rates among the different studies. This data led to now a phase 2 study that again was run by Dr. Westin. And in this study, what we found was among 43 patients, the response rate for an IUD with levonorgestrel, the response rate was around 80%. And again, the response rates seemed to be higher for those patients that have hyperplasia compared to those that had grade 1 endometrial cancer. So I think this data, I would say, is very consistent to show that progesterone is definitely an option for patients with hyperplasia with atypia or grade 1 endometrial cancer. Now, the question is, how can we improve those rates, right? I mean, how can we, if there's a patient that is not responding to an IUD or is not responding to oral progesterones, is there anything else that we can do? So this is an ongoing study that we have in which we are randomizing patients to an IUD with progesterone versus the IUD with progesterone plus everolimus, hoping that the addition of the everolimus would increase the rates of response for these patients. This study is ongoing at our institution, so we don't have the results, but this is kind of like the next step or potential future practice for patients that want to preserve fertility. So in terms of obstetrical outcomes, this study is a study that we did looking at a market scan. It's an insurance database. And one of the things that it's important that I want to just point out in this study is that you can see the use of progesterone, how it has increased throughout the years. So before, like in 2001, it was less than 5%. And when you look at the data from 2014, almost 18% of the patients have that. These are patients that are 45 years and younger, so less than 45. How they use in these patients that are premenopausal, and potentially many of them are using it for fertility preservation, how the use of progesterones have increased pretty dramatically throughout the years. And also, looking at obstetrical outcomes in this study, what we found is that the live birth rate among patients that were treated with progesterone was around 12%. One of the things that was also very interesting in the study, when we look at, and again, this is an insurance study, there are some limitations, but among the patients that achieve a pregnancy, around 50 to 60% of the patients require some kind of fertility treatment in order to achieve a pregnancy. So I would say that based on this data that I have shown, and very consistent with the NCCN guidelines, I think for patients that want to preserve fertility, the use of progesterone treatments are an option. I would say that what we use in our institution, if someone has hyperplasia with atypia or grade 1 endometrial cancer, we take those patients to the OR for a hysteroscopy and DNC. We also do an MRI to assess for depth of invasion. And if there's no contraindications and the patient want to preserve fertility, as long as they have no myometrial invasion, and on the hysteroscopy DNC they have grade 1 or hyperplasia with atypia, we allow them to be we let them use a progesterone treatment in order to preserve fertility. The data for patients with grade 2 endometrial cancer, I think, is mixed. For some of the clinical trials that we have open, we allow patients with grade 2 endometrial cancer to be enrolled. However, I would say that outside of a clinical trial, most people would not allow a patient with a grade 2 endometrial cancer to preserve fertility and use of progesterone treatments for a grade 2 endometrial cancer. But again, we have some studies in which we allow patients with grade 2 to be enrolled in clinical trials. So these are the NCCN guidelines. Again, patients with grade 1 endometrial cancer or hyperplasia with atypia, if they have a confirmed biopsy after a DNC hysteroscopy and an MRI with no invasion, they should have a consultation with a fertility expert plus genetic counseling, and they can be treated either with an oral medication or an IUD. And then we repeat endometrial biopsies every 3 to 6 months. Really, how often to repeat the endometrial biopsies, there's a huge variation, and it really depends on whether the patients are responding to the therapy or not. And the other important question is if a patient has persistent disease or has progression, let's say from hyperplasia with Appiah to greater endometrial cancer, when do we stop? Or sometimes, or whether you should add something else. So if she has an IUD, whether you can also add oral progesterones. I would say that the data about what to do in those situations has to be individualized, and there's really no really high quality of data to do in those cases. So I think in those situations, I would say that if you don't have experience dealing with those situations, it's better to talk to someone who's seen regularly those kind of patients, and whether you should proceed or add something else to try to see whether the patient might respond or not. So the other big part is about ovarian preservation for endometrial cancer. So the standard treatment for endometrial cancer is a hysterectomy with bilateral salpingo oophorectomy and pelvic lymph node assessment. For patients that are premenopausal, there is data to suggest that we can preserve the ovaries. This is a study that was published by Jason Wright back in 2009 in JCO, in which he showed in a retrospective database study that ovarian preservation might be safe for some patients with grade 1 endometrial cancer. These analyses have been replicated by other groups, and I would say that the data so far has been consistent in terms of showing that preserving the ovaries for premenopausal women in certain situations might be appropriate. I would say that I want to highlight in some situations, I would say that there's still a risk, like a 2 to 3% risk of having a synchronous ovarian cancer for these patients. And actually, synchronous ovarian cancers are more common in younger women. So every time that we have a patient who is, let's say, 40 years old and wishes to preserve their ovaries, we have to have the conversation that, based on this data, seems to be safe, but they are potentially taking some risk. And I have had a couple of patients of my own in which they've been diagnosed with ovarian cancer subsequently. So I think this data supports that approach, but I think the counseling is super, super important if we want to preserve the ovaries. So now I'm going to briefly talk about cervical cancer, and I'm going to focus more on radical trachelectomies for cervical cancers. In the United States, we see around 14,000 new cases of cervical cancer every year. Around 4,000 women die every year of cervical cancer. As you know, cervical cancer is much more common in third world countries, in developed countries, and that is where most of the cancers are being seen. In terms of fertility preservation, what's important is that around 50% of the patients, at least in the United States, are diagnosed with stage 1 disease, in which the opportunity for fertility preservation exists, and also that there's a large number of young patients, a large number of patients with stage 1 disease actually are women less than 45 years old. So this is something that, if we see a patient with cervical cancer who is young, this is something that we actually can see quite commonly. So radical trachelectomy involves removing the cervix and also the parametria. It's a complicated operation. It's a very technically intensive operation with potentially risk of complications. And I would say that very few centers have experts that have enough volume to do these procedures. And it's not only about removing the cervix, is removing the cervix at the parametria, and also at the end, for many situations, we do a cerclage, and then suturing the uterus to the vagina. This is data from Mary Plant that was published now probably more than 20 years ago. These are the indications for fertility preservation for early stage cervical cancer for patients with stage 1A1 disease. So that means tumors less than 3 millimeters, microscopic. Doing a cone or a lip nowadays, I would say it's appropriate if patient wants to preserve fertility. Where I'm going to focus more if patients with stage 1A2 on 1B1, that means that the tumors are invading more than 3 millimeters. So for those patients, what it's one of the key criteria is having lesions of less than 2 centimeters, and that it's limited to the endocervix. And we have to make sure that there's no evidence of pelvic lymph node metastases. In addition to that, for most patients, we restrict this to histologies that include squamous cell carcinomas, adenocarcinomas, and adenosquamous. And for other unusual histology types, we very rarely will perform these procedures. There are different routes in which you can do a radical trachylectomy. There is a lot of debate about whether you can do laparoscopic or you should do laparoscopic abdominally. There is data in cervix cancer suggesting that doing minimally invasive surgery can lead to worse prognosis. So I think there's still a debate whether doing a laparoscopic radical trachylectomy is appropriate. But I would say that in our institution, we're doing these procedures now through an abdominal incision rather than laparoscopic. More importantly, the recurrence rate is 4% for these patients that have a radical trachylectomy. And again, we restrict these to tumors less than 2 centimeters and that have the most common histologies. This is a study that we published 2 years ago looking at data from the California Cancer Registry linked to birth data in California. And as you probably know, if you do these procedures for fertility preservation for early stage cervical cancer, there's risk of obstetrical complications. And the most common risk is preterm delivery. For what we saw when we compared to controls, patients without cervical cancer, the risk of preterm delivery, the odds of preterm delivery of less than 32 weeks was 6.27 for those patients that have a history of cervical cancer. So every time that we do these procedures, the counseling is very, very important because the risk of preterm delivery leading to neonatal morbidity can be quite high. So can we offer these procedures to patients that have tumors more than 2 centimeters? And again, keep in mind that the bigger the tumor, there's a higher risk that there is parametrial invasion, and therefore patients might have high risk of recurrence. And there is some studies, I wouldn't say that have been very consistent, but some studies have suggested that for patients that have tumors more than 2 centimeters, the risk of recurrence is so high that we should not offer them. And again, there's a controversy in the field. We recently did a study looking at what happens to patients that have history of early stage cervical cancer that have fertility preservation. And what we wanted to see is if there's a point in which it's unsafe to offer fertility preservation, depending on the size, for patients with early stage cervical cancer. And what we saw is that really the risk, the 5-year life expectancy, the 5-year life expectancy was really not that different depending on the tumor size, suggesting that for some patients that are adequately counseled, that have tumors between 2 and 4 centimeters, you could offer fertility sparing procedures. The only issue with these studies, as you can imagine, there's a smaller number of patients that undergo these procedures that have tumors between 2 and 4 centimeters. So the 95% confidence intervals are quite wide when you go to those tumor sizes. I think in our institution, there are some patients in which we offer fertility preservation in tumors between 2 and 4 centimeters, but those are very well-selected patients, and they're extensively counseled that the risk of recurrence might be higher for that population. So what about actually, instead of offering for patients that have tumors more than 2 centimeters, can we actually do less invasive procedures? Instead of doing a radical trachelectomy, can we only do a cone or just a simple trachelectomy? So there is data, and I'm just going to go a little bit faster, just for the sake of time, but can we avoid pretty much having to resect the parametria? So can we do less invasive approaches for these patients? And the rationale for this is because in studies that have been done, in patients that have had radical trachelectomies, there's actually, in a large number of them, there's actually no residual disease after they have had a cone. And actually, in patients that have favorable pathological characteristics that I'm going to review in a second, the risk of having a parametrial involvement is less than 1%. So there's this thought that maybe there's some patients that, based on pathological characteristics, we can avoid doing a radical hysterectomy/radical trachelectomy. So this is a study that was done in our institution, and that for the patients that have tumors less than 2 centimeters with no LVSI, the risk of parametrial involvement was essentially 0%. And these are other studies with different criteria, but what is consistent is that if you have tumors less than 2 centimeters, and with different characteristics, the risk of parametrial seems to be very, very small. There are 3 large trials in GYN oncology that have either analyzed this question or are ongoing. SHAPE and CONSERVE. CONSERVE has been published and SHAPE has been presented at ASCO. And we now, and all of these studies have different criteria, but based on the studies from CONSERVE and SHAPE, we know now that for patients that have tumors less than 2 centimeters, and that have a depth of invasion of less than 10 millimeters, now we can offer them a simple hysterectomy instead of a radical hysterectomy. And that's for us that treat patients with GYN cancer. But what's important for fertility preservation is that perhaps we can offer now a cone or a simple trachelectomy, again, for patients that have tumors less than 2 centimeters with depth of invasion of less than 10 millimeters. We're extrapolating from data from hysterectomy, but I do think that this data would be applicable for those situations. The risk of recurrence of doing a simple hysterectomy is 4%, and it's very similar between doing a simple hysterectomy and radical hysterectomy based on the SHAPE trial. So I would say that at this point, we can offer doing a less invasive, like a simple hysterectomy or a trachelectomy for patients that have tumors less than 2 centimeters with less than 10 millimeters of invasion, but we always have to also perform a surgical lymph node assessment. So in conclusion, so for endometrial cancer, hormonal therapy with high dose progesterones or IUDs are appropriate for patients with complex atypical hyperplasia or grade 1 endometrial cancer. We have to follow these patients carefully with biopsies every 3 months until resolution. And we have to offer a hysterectomy for progressive disease or those patients that do not respond. And honestly, patients with grade 2 or 3 disease are not very good candidates for these treatments. And we can left the ovaries inside for those patients that are less than 45. For patients with cervical cancer, radical trachelectomy until now is a standard of care, but there's an option of doing less radical surgery for selected patients with tumors less than 2 centimeters and depth of invasion of less than 10 millimeters, as long as we do remove the pelvic lymph nodes. Thank you very much.
Thank you so much for that wonderful presentation. We'd love to open it up for questions. Does anyone have any questions? Well, I'm prepared with questions. So Dr. Rauh-Hain, so we see a lot of these patients that get treated conservatively with an IUD, but may not be able to afford fertility treatment, or we'll see them years and years later and they still have their IUD. What are your recommendations to those patients, and are there any guidelines for how to manage them?
So I think the most important thing is, that's a tricky question if they don't have access to fertility treatments. I would say that as long as they are not progressing to endometrial cancer, I think it's safe to keep the IUD and let them, I think it's safe. I think if they want to get pregnant, the big question is when to remove the IUD and how often you should be checking them. And what I usually do in my practice, if we remove the IUD, is after they have had 2 normal biopsies, 2 negative biopsies. That's when I remove the IUD. And then after that, we let them try to get pregnant. And I keep seeing them every 3 months just to make sure that they're not progressing without the IUD. I think in terms of pregnancy, I think the data is very clear that many of these patients require some kind of fertility treatment. I think the data, at least 50% of them will require some kind of fertility treatment, IVF, ART. Many of these patients are obese, so I think I always encourage them for weight loss, and I think there's opportunities for other, maybe if they have an ovulation, there might be other options that you guys are experts, and I'm, not fairly ignorant about what is the current standard for those patients. But I think, I would say there's something else that happens to these patients with endometrial cancer that that it's harder for them to get pregnant even after you remove the IUD. I think part of that is obesity, but I don't know if there's something else going on in the endometrium. And I think, Terri, you and I have talked about that. And I think there's that whole area is wide open for research. And I think there's need to be more research to how we can help those patients better.
Yeah, they seem to be some of the most difficult patients to treat because, like you said, they have other comorbidities. They often have PCOS, they're anovulatory. So we usually try to present this 6 to 12 months of treatment as a time to optimize weight. So many of them are starting things like Ozempic, Wegovy to try to lose weight. And when that IUD comes out, even if they're not able to do fertility treatment, we stress like you should be having regular cycles somehow, whether it's taking monthly Provera or something like that. So I agree, these patients are tough. And the other thing that we've noticed is that a lot of these patients, and I don't know if it's the recurrent, biopsies or repeat biopsies, you will see that some of them will have intrauterine adhesions that we have to take down hysteroscopically. So I have a pretty low threshold for just doing another scope in the office or the OR for these patients.
Yeah, and for us, like the other part is that once we take out the IUD or stop the hormonal treatment, there's always the fear that they're going to lose to follow up. And I have had patients that just disappear, and then 2 years later they come back, and then again they can have hyperplasia or grade 1 endometrial cancer. So just making sure that they don't get lost is super, super important.
Dr. Rodriguez-Wallberg, question for you. So a lot of patients that have either borderline tumors or ovarian cancer that's early, who may have an oophorectomy, cystectomy, how do you counsel them? Because sometimes they come in and say, hey, I lost one ovary, my ovarian reserve doesn't look so good. How do you counsel them in terms of family building and future fertility?
Yes, I think for all these patients that have a risk, for example, the patients that Alejandro mentioned that have had an endometrial cancer and they decide to remove the IUD to attempt pregnancy, we have to let them know the importance to get pregnancy as soon as possible so they can complete the treatment after delivering a child. Of course, if we could offer fertility treatments to all of them, so the best idea will be just to help them to get pregnant as soon as possible with assisted reproduction, for example. So the young patient that have removed one ovary, most of the patients with one ovary can have a quite normal fertility. If there is an effect in fertility, the effect doesn't seem to be very, very important. But there are some types of ovarian cancers or even borderline tumors that have a higher risk of recurrency. And the patient needs to know about this because they are taking the risk at the moment they decide to keep the other ovary in place, that they have a risk of recurrency. So sometimes we receive the referrals from the gynecologists or gynecologists telling us that the risk of recurrence for this specific patient is high, or in that case, the patient is still 20 years of age, probably far away from the age she would like to have a pregnancy. So they send the patients for fertility preservation, and we stimulate the patients and preserve oocytes for the future for many of them. Yes.
This is a question for both of you. Do you feel like conservative management is becoming more common? Because there was a time where everyone would come and say, I was recommended that I get everything out. And we still see that sometimes. But do you feel like the trend with more younger people having cancer and delaying childbearing, that providers are being more sensitive to this issue?
Yeah, definitely. I think that we are not treating the patients today as we did 20 years ago. 20 years ago, probably we considered that hysterectomy and bilateral oophorectomy will be curative for a woman with an endometrial cancer, even if she was young. And that was the treatment we used to offer. Well, maybe 20 years ago, I think that was the rule.
Yeah, I think if you look at, sorry, go ahead.
No, we think differently now. Today is very different what we say to the patients.
Yeah, I think if you look at the data from all GYN cancers, I think it's very evident that we are doing more fertility preservation now than we used to do. for sure.
See something in the chat here.
Yes, I was just
Dr.
making a comment, Terri,
Okay.
that in addition to sending patients for fertility preservation with one remaining ovary, we also suppress the ovary if there's no contraindication with like a progestin daily or continuous OCPs to minimize the risk of benign cyst formation and torsion and cystectomies. So that's always a challenging discussion when children are like immediately post-pubertal and there's no real other indication. We just want to pay close attention to them that they don't have some sort of catastrophic occurrence to the remaining ovary that could have been prevented.
Dr. Rauh-Hain, can you comment a little bit? You talked about trachelectomy and the higher risk for preterm labor and delivery, but you know, often you guys place a cerclage. Can you talk a little bit about that? Because I don't think a lot of people necessarily know that.
So it's a very good question. And actually, there is a debate in the field whether you should do a cerclage at the time of doing the radical trachelectomy or whether you should wait after, you know, at the time of pregnancy. I think for us here at Anderson, I think we do the cerclage at the time of doing the radical trachelectomy, thinking that all of these patients are, or the majority of the patients are going to achieve a pregnancy. But that's how I think we practice, or I think to me it makes more sense to be honest, but I know that there's still a debate in the field about when to do it.
Yeah, and I think just talking with our MFMs and just to make a point about having good collaborative efforts between Gyn-Onc, REI, MFM to help counsel these patients preconceptually so that they know what kind of things they might be getting into during their pregnancy so we can be proactive. But like I know over at Texas Children's, the MFMs over there are really pro putting in cerclages before people become pregnant, rather than, you know, taking the risk when they're already pregnant of PPROM and so forth.
Yeah, I think if we're going to do a radical trachelectomy, all of those patients are seen by an MFM before we do anything because it's super, super important.
Could I ask a quick question about the Swedish data? So thanks for that presentation. I'm curious as to, among all of your linked databases, are there laboratory data, like laboratory values, for example, ovarian reserve measures? And then in the treatment data, are you able to delineate different chemotherapy regimens?
For your first question about laboratory data, there are not laboratory data in the registries, or only registries that have decided to have that data because the registries request what is the data that will be sent to them. For example, in the quality registers for cancer, so they request the histological data, the tail data of the diagnosis, the stage, the size of the tumor, many things, but not laboratory data. So reproductive data, hormonal data are not available in any registries. We have a quality register for IVF, and we have the variable AMH in the clinical charts, but it's not exported to the registry. So it's a possibility to still create cohorts, and then you can upload your cohort and request the other data. And it says what we do in cohort studies.
Thanks. And then in the cancer registry data or in their medical record data, are you able to get regimens, cancer treatment regimens?
The regimens can be found in the quality registries if they have decided to get this data in a detailed way. And I don't know if they only, for example, register the cumulative doses of certain drugs, or if they have a detailed data, or if they have just the planning data. I'm not sure about this, but some data are available in the quality registries of cancer, but not in the general cancer registry. This is in the specific breast cancer quality registry or other specific disease quality registry.
The only reason I ask is because I feel like we do risk stratification for kids largely from studies like the CCSS, but you have an opportunity to do some risk stratification if you had the regimen data given all of your linkages.
Yes, this is a very important. Aspect. Of course, we are aware about this, but there are other ways to get close to that data, but not directly from the register. We have to work to create this information linked.
Thank you.
I'd like to thank everyone for their participation. The speakers, you did a wonderful job, and thank you all for attending. We're right at 4:01. So Dr. Appiah, would you like to close us out?
Yes.
Can I
thank
still
you.
ask a question? Is that still possible?
Is that a question?
I would like to know from Professor Rodriguez, whether you have any experience with cryopreservation of oocytes in patients with a dysgerminoma of the ovary. Do you have any? Because in the literature, there's hardly any data available. So,
Inge, may I offer one thing? May I close out the webinar and then perhaps stay on so that Dr. Wallberg can answer your question? Is that fine?
yes, of course.
Okay. Thank you everyone for joining. We appreciate your time and your attentiveness. The webinar link will be placed on the website for the Oncofertility Consortium for your review. And thank you so much for our speakers today. And Dr. Woodard, thank you for moderating. Everyone have a good evening. And Dr. Peters, please stay on the line with Dr. Rodriguez-Wallberg. I will also stay.